presentation, people think, of course, about languages and practices and beliefs, values, customs, but they sometimes forget about the courtesies, the rituals, and even the manner of interaction and the roles and relationships that we have with each other. That's where I want to begin this kind of presentation in broadening our view about understanding culture. And the important lesson is, why do we need to be culturally competent? I often hear, sometimes from very individuals who are kind of just coming into the field, take the general approach, well, don't we just treat everyone the same? And that means treat everyone with respect. Well, of course, we're going to treat everyone with respect, but we also need to recognize the range of diversity. And I know I don't want to appear to be speaking to the choir here, because you're all experienced professionals in your profession. But we still need to sometimes remind people of the very basics that we start with when we talk about understanding the diversity of our populations. More importantly, it's understanding how the diversities of the different communities can also impact how people receive and or benefit from health practices. In expanding our cultural competency, we look there's three core aspects of cultural competency, and that's our purpose and our knowledge, our attitude, and our skills. So as we look at these, I want you to be mindful of where you may see yourself in the knowledge that you have, the skills that you have, but also it's important that we reflect on our own self-awareness and our own attitudes of where sometimes we might hit our own little stumbling blocks in working with individuals that are vastly different than us. I think sometimes there's more of a gray area that there's certain, even though there's differences, we might have a shared similarity around certain beliefs and or aspects that are easier for us to work around, but sometimes we can really hit what's referred to as a cultural collision, where our belief structure and our attitudes can be vastly different than someone else, and it could actually create almost a separation about how information is sometimes transpired. So again, our purpose as health professionals, we want to basically improve the healthcare system for those in the diversity of the populations that we're serving. So again, our own attitude becomes really more important. It's our willingness to adapt to the needs of the clients and their family members, and to meet those needs in an objective, non-judgmental way. I think I just really like to emphasize that anytime we study cultural competency, the onus is more often on ourselves than it is on the readiness of the populations we're working with to receive the information. It's more about how are we interacting with them in providing the information. And of course, that then gets amplified by our own skill sets that we do have and that we do possess as public health professionals. So cultural context is actually giving meaning. It's a filter for which people process their experiences and their events. It influences how people interpret things. It influences their values, their actions, their expectations of themselves. But it also impacts people's perception and expectations of others. So again, we don't always know how someone is viewing us when we're giving them certain information or just performing the duties of our job as public health professionals, because we may be, they may see us as something other than as we truly are because of their own past history, either with individuals in authority, healthcare providers, past experiences, something that might have occurred in their original, religion, ethnic group, demographic group, whatever else they could have experienced in their life. And we're not always fully aware about why that might affect some of their interaction with us in the present day. So again, just a reminder, it's cultural competency is recognizing and then developing the appropriate response that key into some of these key cultural features that affect the care that we give. And again, the end result is that we want to get to healthy outcomes for everyone in our communities. I like referring to the work of Dr. Peggy McIntosh, who is a very well-known scholar in academia on culture. And she has recognized the influence that privilege can have for somebody. And I've been in experiences, or I've been in interaction with other individuals that sometimes even the use of the term privilege is often misunderstood. And I believe part of that misunderstanding is many times the more privilege someone might have, they might be less aware of actually having that privilege. But as we continue our expansion of cultural competency, we do take, and that's where that attitude and beliefs come in, that we can also say, oh, now I see what other people are seeing when they look at me and perceive me as having a position of privilege. That doesn't mean that everyone necessarily does have privilege in their own personal life, but that can also be how they are perceived. And then there are other individuals that actually do possess privilege, and they tend to ignore the fact that that privilege can impact how they interact with others. So when we look at cultural competency, there's stages that we go through as far as building our awareness. Many times individuals come in just with that unconsciously unaware, just not even impacting that culture might make a difference in the delivery of services. And as they move through that, they start recognizing that they become a little bit more sensitive to their understanding. So they're becoming conscious of it, and yet there's some unaware about what they need to do or how they could actually do that. Eventually, we hope that they move into that level of competency where they actually become consciously aware, okay? So that when a project is being discussed, someone at the table is going to say, oh, wait a minute, I'm thinking, how about with this segment of our community, or have we thought about outreaching, or how might that be understood, or how would those hours be reflected in other groups who might not be available at certain times of the day or certain days of the week. So that's when we become much more aware of it. Same thing with language proficiencies. And eventually, when we reach the level of cultural competency where we have that proficiency, it's not a question of being reminded that we need to be consciously aware, but we are ready, and we can do that as just part of our natural ability in our interaction with others. And many people are able to achieve this. However, there are often some stumbling blocks that we do have, and this goes back to how we reflect on our own understanding of culture and diversity. Some of them for us are a little bit more obvious. And then there are others that are a little bit deeper, and sometimes we do need to dive deeper into what might be some of our own biases that we possess or own, and or the communities that we're working with, and what might be standing in the way of them receiving good health education. Now, some people have already moved beyond and said, I'm not sure I really want to support cultural competency as the end result. Perhaps it's better if we take approach to utilize cultural humility. And cultural humility is a kind of a shift in how we approach cultural diversity. It's basically, and you can, of course, on the slide here, I'm not going to read everything on the slide. It's really reminding us that if we are truly have and practice humility, we're willing to learn from someone else what they need. It's the basic premise. It's like, I'm not really sure how to best serve you. Why don't you tell me what you think you need, and I'll see what I can do to help meet that needs. That's having the humility to ask more questions of the individuals that you're, or the communities or the groups that you're working with, as opposed to coming in saying, well, this is what to my understanding is going to be more beneficial to your particular group, so let's try it this way. It's more of opening culture. In cultural humility, it's actually another way to define that is just looking at establishing a better collaboration around communication and also identifying needs. And in order to be sensitive to the patient's culture, then we also must possess some level of cultural humility also. Again, when we talk about culture, there are times that there are some parts of culture which are very, very significant. They stand out, but I want to be mindful that there's many different core aspects to an individual's identity and what that might contribute to one of their own culture. Now, if you're looking at this list here, you can think for yourself. These are, an assortment of different terms that we are a little bit more familiar with, or classifications, we could say. You can ask yourself, well, which are the ones that you personally, in your own personal life, are important? Do you relate more to your appearance? Do you relate more to your education, your socioeconomic status, your family of origin, your race, your ethnicity, your age, your sexual orientation, your abilities? Which are the ones? So it's not a question of finding out which, there's not a general priority. It's more of each individual will have their own understanding of their own self-identity as it pertains to their culture and where they see their own range of diversity. So let's clarify a little bit more about diversity, because diversity is a very significant part of understanding cultural competency. So there are many different aspects of diversity. And again, if we look at this cycle here, or this circular image, certain things might just kind of stand out for you. It's like, oh, that to me is really significant. And in other areas, we might personally think, oh, I don't really give much thought to that. You know, I don't think my age makes much difference in how I do my professional abilities. But then at the same time, your age can reflect to somebody else how they interpret or how they look at you as far as in delivering of your services, or their particular age could stand up. So again, there's just that diversity that exists with who we are and also the communities that we're working with. So we also can consider that when we look at diversity, there's a range of experiences that we have in our diversity and in our own identities that become very central and core. And these, as I mentioned in the first earlier slide about some of those dimensions of diversity, we also recognize there are some that are considered more primary to the individual. And in those primary, people sometimes have a stronger connection. And then at the same time, when we look at the secondary dimensions, so again, I think the terms primary and secondary are pretty self-explanatory, but when we're looking at it from a cultural perspective, someone's race can play an important component, but then also what that means for them is their geographical location, their experience, their family, work life, and community, everything that affects them within their community can also be slightly different. So again, there's these different dimensions of diversity. Another way to look at this, another model that I like to reference is when we look at an iceberg. Now, of course, we were probably all learned in geography class or back in grade school about how the iceberg, the tip of the iceberg is only what you're seeing on the surface, but the larger quantity is and mass is actually what's below the surface. So when we apply that culture or to being like an iceberg, there are certain things that are very observable behavior that we might see, but there's also that set of things that are invisible and they're out of our conscious awareness. Now, of course, at some point, something that might be considered invisible might come to the forefront and be more visible when there's like a designated observation, let's say, or a celebration, or something like a Heritage Day or a Heritage Month or something like that. So people might then share with others some of their customs, their food, their dress, their language, and their celebrations. But many times, unless it's being highlighted, that might just be more something below the surface that is more personable to them, that might not always be as relevant or come out and be as obvious to others that they're interaction with. So again, we look at both the observable and then the invisible. The other thing, and again, this is where I think the title comes from that I'm using for today's presentation, is we're evolving our understanding of the racial categories and cultural identity. Remember that for many years, race in the continental United States was divided by either being black or white. And we know that that term is very, very limited. It's not, that's not how we categorize people. And yet that was kind of the foundation of how we looked at racial differences. So we expand then and look at that when we talk about race and ethnicity, we're not just talking about one particular skin tone or categorizing every skin tone other than white as being in the same group. I know that's kind of basic, but I always like this kind of image, because if we say, as just like a box of crayons, if a color in the crayon is referred to as flesh, well, whose flesh are we actually referring to? Now, in addition, okay, and I'm going to go into this a little bit deeper in a few minutes, that many times when we talk about cultural diversity, we look at language skills, reading skills, race, ethnicity, religion, and even disabilities or limitations or accessibility. We forget sometimes there are other components, and particularly I'm going to talk about gender inequalities and sexual orientation that also can impact an individual. and the community themselves. There's also the mental and physical disabilities, okay, that can also be compounded by someone's sexual orientation or gender identity, and that can also affect the quality of their life. So I often find that when people are teaching cultural competency, one of the parts that is left out is that opening up the broader understanding of how also sexual orientation and gender identity needs to be recognized and included in developing culturally competent care. Again, so our basic premise here is that we want to be responsive and respectful to the beliefs, the practices, culture, and linguistic needs of diverse people and groups, okay? And then we are actively addressing how to deliver these services in appropriate manners. And again, the end result is we're going to reduce health disparities and improve the access for outcomes. So how do we do that? Well, there's several different components that become important when we're focusing on cultural competency. And this goes back to our role as the provider. What we do within our systems, what we do as far as communication, education, literacy, also recognizing the family dynamics and the basic health beliefs of individuals and how individuals in certain communities are going to interpret medical or healthcare practices or public health practices slightly different. In the interactive presentation that I do, I sometimes ask people to think about what it was like growing up. How often did they or members of their family visit a doctor? Did they go to see a doctor for every incident that occurred in their life, every time there was a cough or sneeze or an ache or pain? Or did they only go to a doctor when it was a more serious consequences? And if it wasn't perceived as being as serious, where did they get their health information from? Many people relied on what we consider to be part of like folk medicine, or just was kind of passed on from different generations. You have this is a good way to handle it. So, and again, it goes back to how in the demographics of what we experienced in our growing up can also influence how we think other people perhaps would also access healthcare. And that can be very different for each group of individuals. There are some individuals that going to a doctor was a major event, or they just didn't have access to going to see a doctor. Wherever it could have been in a remote area, or it just wasn't financially or other reasons that might have been less available to them. So that can also create some of a health belief for some individual. If you didn't have ready access to certain healthcare institutions or doctors or facilities, then you sometimes started conditioning yourself or starting the belief system for yourself, like some of the things are not really relevant. And then of course there are others, and I go back to just the example of asking people, so if you had a cough, what did you do? And you know, how did you handle certain things that were going on as far as your health understanding and beliefs? That kind of brings up the issue that there are things that might be considered very acceptable in one culture could be very unacceptable in another culture. And even the way we interact with people, there is disparity that might exist when we are asking someone to complete a health survey or to answer some health questions, depending on the differences between different communities. Some people might be more comfortable being very upfront about discussing certain health practices or certain beliefs, or even just their own health and well-being, and others might be a little bit more guarded about discussing some of that. There also might be certain things that people might do therapeutically to help themselves that other cultures do not consider to be appropriate or even necessary. So again, we hope to continually broaden our understanding of diversity, okay? And as we do that, we're valuing the diversity, and that we're accepting that, recognizing and people coming from different backgrounds, and with that comes all their thoughts, their ways of communicating, their values or traditions, and also some of their institutions. So the choices that an individual make are actually very powerfully affected by their culture. I had a wonderful experience where I was asked to go to several different states to review their mental health delivery services as far as working with individuals with co-occurring disorders. And part of the project. It was a state co-occurring initiative grant that we were looking at. Money was designated to improve cultural competency care around mental health services. And we went to different states to see what they were doing as far as outreach in these different areas and geographical locations. So when I went up to Alaska, they were very, their discussion of how individuals might access mental health services was vastly different than when I went to Maine. It's not just a difference in the environment, but actually the environment also creates other difficulties for them. In Alaska, they spoke about many individuals come from very remote areas that become landlocked during the winter season. There's no way you can get in and out because the roads are not accessible. What is usually brought in is usually airlifted in, or is brought in under different ways, or with vehicles that are not usually accessible by individuals. So in that particular village, no one is going to come in for a weekly appointment with somebody. So they have to anticipate that for several months out of the year, they're going to be in this very isolated environment, where in another state, it's like, well, we need you to come to the clinic, we need you to come to the health office, whatever, and people have much easier access to those, receiving those particular services. The other thing, and again, I hope I'm not preaching to the choir here, is that sometimes we do recognize the diversity, but we don't always consider the diversity that actually exists within the actual community or cultures themselves. So some of us have been exposed to many different cultures, and a lot of us, we can get information from other activities that we're involved with, what we learned in school, what we see on TV. All those can give us opportunities to experience a more multicultural exposure. But we also want to be mindful of that, because we have one understanding, we don't try to apply that to everyone of a particular culture or a different group. The mistake there would be people make assumptions that there's a common culture shared between members of different racial, linguistic, and religious groups. Now, they may have some shared beliefs or some common experiences, but then there may be others that really beyond the physical experiences, the common language, or their spiritual beliefs, there's a lot more diversity that might exist within that community, within that culture, than what others who are less experienced in working with individuals in that culture may fully recognize. So, many times in reviewing diversity, I think it goes back to our understanding of those primary and secondary characteristics. Race is often the most strongest one, or the first one that people become a little more, it often can be, but not always, more observable. But again, it's to be mindful that the racial construction of a group is only one component. There's other considerations that we need to make. So again, we need to continually expand our understanding of diversity as we are becoming more culturally competent. And as we become culturally competent, I'm going to restate that we could also shift into also becoming, maintaining cultural humility. We're always willing to learn from others what it means for them, or how they see or how they relate to the information that we're sharing with them, or the health aspects. So that is a overview of some of the challenges. Here's an overview of some of the challenges that we have, that sometimes might occur when we are in situations where we are working with diversified populations. One of them, again, each of these can mean different understandings for each of you. But I think early on, I remember hearing someone say, well, they're actually, and they mentioned a group, and then almost implying that, well, so everyone in that group kind of acts the same way. And that is really just a stereotype, or making biases and assumptions based on someone's race or ethnicity. And then sometimes we ignore the fact that we might be having this kind of cultural mismatch where we really are experiencing this collision, and we have to work a little extra hard on our end to move beyond that. So let's kind of break that down. So how do we get into how do we look at some of these challenges? Well, I think one of the first things we look at is when we become more consciously aware of some of the stereotypes that do exist. Stereotypes basically attribute characteristics of one or few members of a group to the larger group, but stereotypes can also be positive or negative. But we often consider first, or we often reflect first on some of the negative stereotypes that we have and undermine some which might actually be considered positive. And actually, for some individuals, those positive attributes might actually be a good cornerstone of what else they need to build on. But the important thing is that we not assign these to all individuals in a particular group, because that is actually moving towards having more of a prejudice, where then we start making very broad general assumptions about individuals based on either hearsay or emotion, anytime one particular group is the point of reference. So stereotypes can often be considered to be negative or positive. Prejudice is usually not considered to be positive, okay? And then we also can experience, sometimes there are certain myths that we have where we believe something was true about a group of individuals or a collective. So we think that actually, well, that's pretty much how we did it in the past, so shouldn't we continue to do that? And I always remind people that I'm working with, sometimes the worst answer we can give is when we tell someone, well, that's usually how we've always done it, okay? And again, it goes back to having cultural competency and cultural humility. We're open to understanding there might be different ways that we can approach certain campaigns or education or materials, okay? Even though it may have worked at one time, it doesn't mean it's always going to work. And we definitely find this when we look at some of the broader diversities that exist, when we talk about race, age, demographics, sexual orientation, can kind of play into what people now believe they need compared to what they thought they needed maybe going back 15, 20, 30 years ago. We also recognize that there are many times that stigmatized populations or minorities also experience a different level of minority stress, okay? And minority stress, we understand that to be, it's based on the interpersonal prejudice and discrimination that many people feel. I want to bring up the topic that we also, for LGBT individuals, their minority stress is also going to be different, and how they might feel they are being treated because of their race, ethnicity, language, religion, culture. If they are also part of a subgroup of being an LGBT minority, then they are going to experience a different level of stress, which can also lead to a decrease in protective factors and an increase in some of the risk factors. So I'm just going to give you, this is a very brief, I have a full, half-day presentation we do on the LGBT population. I'm just going to integrate it here into this webinar for a few slides and then continue on that again. And the reason, I believe one of the things about offering it this way, because we traditionally, when we talk about culture, we sometimes make that unconscious bias to first just consider racial differences. This is a good model to look at. So there's so many other broad differences that we might experience, and how does that also transcend then into the other ranges of diversity that we're interacting with, okay? So just some of the terminology that is used and how a terminology is used. And here, the example I want to point out is that everyone in the community or even outside the community doesn't always have the same understanding of the terminology that a group might actually use. Sometimes in research, we see just SOGI, sexual orientation, gender identity, and expression, actually being a term that is being used as opposed to LGBT, but both can be appropriate. But talking about terminology from the LGBT perspective or from sexual minorities, that it is always expanding, okay? And we can talk about our basic sexual orientation, and then we also talk about gender expression, which is different. So here we see where there's diversity, there's a group which we consider to be sexual minorities, and in their sexual minority status, there's other levels of diversity that might exist, okay? Also see that there are some allies that exist that might be a part of the above mentioned group, but they actually can be more supportive or also concerned about the needs of others within a group. And we'll talk about that in a little bit. Again, this is the very modified version, but some people I've experienced get very confused when we talk about a gender identity versus sexual identity. So identity begins in our brain, what we think about, how we relate and how we relate to our gender. Attraction is who we find ourselves attracted to. Sex refers to the biological differences that we might have. And then we put that all together and that becomes part of our gender expression. The important thing, and particularly if you're working with diversified individuals, is we learn more about what terminology and language that they use. And particularly here in this example, I'm going to go back to, for a transgender individual, their use of pronouns and nouns can be very different than your use of nouns and pronouns. You always have to be open to the fact that not everyone likes to identify as either he or she, male or female. So for some individuals, gender can be more fluid. Again, I'm using this as a model about how there can be a broader understanding of diversity than just a very basic, simplistic understanding. In our simplistic understanding, we can sometimes refer to that as a binary approach. So when at one time in our culture, we looked at racial differences to be either black or white, that's binary. It was always, we came back to one of two options. And we know that that doesn't fit, so we can also then kind of move beyond that binary system to look at, for other individuals, it also might not be a simple between one or the other, be it black or white, straight or gay, young or old, okay? There are certain health concerns that the LGBT also experience at a greater level, and this is often compounded by the discrimination. So just because a person might identify as LGBT doesn't necessarily mean that they're going to have certain psychiatric or substance use or be suicidal, but the victimization and how they are treated in society and a culture can greatly influence whether they have some of these other risk factors, okay? And again, I never say that, I try not to make comparisons between different groups as to say that they are all similar, but we do know certain populations that they experience a higher level of discrimination, and as a group, they're more familiar with how to better protect themselves from harassment or mistreatment. Going back to, I just want to emphasize again, the reason why this becomes more important now as public health professionals, in 2016, so 3 years ago, Morbidity and Mortality Report came out, and they did a research where they looked at health risk behaviors on grades 9 through 12. So the research was data, it was collected in 2015, and then it was published in 2016. This was part of the Youth Behavioral Risk Survey, which we do in our state, but the reason why I'm using this particular example is year they asked specific questions about sexual orientation and or sexual identity and or sexual behavior, okay? So students that said either they had been sexually involved with someone of the same gender or the opposite gender were categorized, and is that the end result, the outcome of this measurement was, we look at some of these, look at the rate. Now the first set of numbers that you're seeing are individuals who either self-identified as being gay, lesbian, or bisexual, and or having had a sexual experience with a member of the same sex, which means they might not self-identify, but their behavior at some point might have increased their risk factors. But look at the general risk factors that, among our this is a high school population, 9% of the adolescents have attempted suicide. When we look at those that are either, again, as I define that group, self-identified and or by behavior, it increased 35%. Risk of hurting themselves, carrying a weapon to school, being bullied on school property. Being bullied is doubled for those LGBT youth. Marijuana, I always find it kind of interesting. I know that in our society, in our state now, we're currently approaching a ongoing about marijuana. Does it need to be decriminalized? we do have medical marijuana, but what about recreational marijuana? And I often hear less enlightened people say, well, our greatest concern is what's that going to mean for high school students? They're now going to think it's okay to smoke pot. Well, the Yervis report that we got back then was half our high school students were already using marijuana, and students, 79% of them were using marijuana. That's a very alarming statistic. This is online with the topic that if we're developing, information, and we do know that yes, marijuana can affect brain development, so therefore there's a good reason why young people should not be using it, but our educational information that we put out there has to be factual, not based on some old stereotypes we used to put out, such as this is your brain on drugs. Why that might have been an entertaining commercial for some of us who remember it. It never really got the point across to members of the identified group that perhaps we were trying to give a preventive message to. Right? We also in our state are experiencing a heroin epidemic. Talk about young people, those that are using heroin, we see the numbers here at 2%, but again, with our LGBT individuals, we see up to 17%. The challenge for me then is what information are we giving that's specifically designed to do outreach to the sexual minority individuals who are already potentially at risk of an overdose, a fatal overdose, because they've already have initiated their initial use to using opiates. And it goes with use where we see it has gone up, which for some becomes the onset of opiate addiction when they start using first the prescription form and then moving on to injectable forms. So just some considerations to look at as far as our health risk behaviors and how it might be different for different populations in our state when it comes about sexual minorities. The interpretation here is, of course, that the majority of sexual minority students cope with the transition from childhood to adolescence, through adolescence, is very successful, become very healthy and productive adults, but then for some individuals, some of their health risk behaviors compared to sexual minority to others, okay, it's confirming that we're seeing this greater health risk. Therefore, this might actually continue on into adult life, adult experiences, so the overall effect on the quality of life. A little bit more statistical information just to working with sexual minorities. We see the suicidality rate is exceptionally high. And again, our state has a suicide prevention plan. We're supporting the zero suicide initiatives that are being developed, and we need to be also inclusive that the risk then for many who are sexual minorities could actually be greater. Therefore, their information needs to be appropriate for them. A point of reference there is that there's a national suicide prevention line. There's actually a couple of different numbers that might go to the same call center, but if you call the Trevor line, Trevor is the individual picking up that part of the National Suicide Prevention Network. That line is dedicated for LGBT individuals. So it kind of bypasses what might be an awkward moment for the person calling to discuss their sexual orientation or their gender identity. They're calling a helpline that's specifically set up for them. That is very similar to we have a designated helpline for veterans, for law enforcement, and for first responders. So again, I want to be clear though here that we're not saying just because someone might be LGBTQ that they're necessarily, that's going to cause them to have a serious mental illness and or an addiction. But the challenges that they face, discrimination that they face can also lead to an increase in some of the risk factors and a decrease in the protective factors. I often get asked them, well, so what are we supposed to do? Well, I think that, it begins with how do we actually start our interaction with other individuals? What questions do we ask, Again, I'm going to make the comparison. When we ask someone about their race, if we gave them a box that had 2 check marks, you can either say you're black or you're white, many people would not answer it, refuse to answer, or just write in and say, that doesn't describe me. But I think we can learn from that and also look at sexual orientation and gender identity. There's different ways individuals can be asked. If this is something that your programs are looking to expand on because you do a health needs assessment or you do any kind of questionnaires, you can go to the Do Ask, Do Tell website, which is part of the Fenway Institute, and or I'd be very happy to help you develop whatever intake forms or assessments you might be working with. And I do know in our state, we are now particularly starting to capture a different level of identifying markers. I believe those projects that were receiving funding from the Brian White grant to also ask more specific questions around segmentation and gender identity. But that's not across the board in all our healthcare. So kind of summarizing here, okay, there's a whole range of diversities and communities, and there's also the different ways oppression can affect all of us. But universally, there is a connection. When you have individuals that are feeling oppressed, then there's going to be a lack of connectiveness to their delivery or their receiving healthcare services. So if we look at, and again, I know I gave the example, I was focusing with the gender and sexual orientation, because that is often what I greater misunderstanding that might exist. But look at this matrix of the different, go back to the different categories that we have, okay, be it race, sex, gender, class, abilities, disability, religion, and age. And some groups could be identified as having privilege in that particular group. Some groups might be marginalized as far as having some privilege or experiencing some privileges, and then there might be others that are definitely more the targeted populations that are definitely feeling the inequality or the health disparities. And then also there's just mentioning the different ways that is this is also this sort of, but again, look at those determinants. I'm hoping that we become a little bit more expansive, and that's why we're going a little deeper into our understanding of cultural competencies. That we look at the broad range of social determinants that might exist, which is why I like using this particular model, because you see that there's different elements, different levels to our social determinants of health. Okay. I'm going to be wrapping up. I want people to be prepared to answer any questions, or they can type in their questions and answers. I just kind of, in summary, use a personal story that someone shared with me. Several years ago, MGM Grand in Las Vegas wanted to rebuild their building. They were basically reconstructing their building. Now, they identified they had a number of tourists who were coming in from Asian countries. And in the gaming industry, particularly around responsible gaming, there's a lot of competitiveness to capture people coming into their particular business. So MGM Grand said, you know, there's this large influx of people coming in on these group tours coming from Asian countries, specifically to come to Las Vegas with the availability of so many different forms of gambling. There's probably other things that happen in Las Vegas that isn't really relevant to this conversation, but the point is that they wanted to make an entrance that would be appealing to the Asian populations. Individuals coming in from the airport, they come in on one of the shuttle buses, or even on a limo or taxi, whatever. They're in the center of town, and it's like, okay, which casino are we going to? Which hotel are we going to be going to? So in Asian culture, the lion is very much revered. So they decided, let's make this entrance to resemble that of a lion and a lion's mouth, or a lion. And they thought this was a great idea, okay? What they thought was a great idea was not really a very good idea, because what they found out after constructing it, now this is an actual postcard image of the original redesign of the building. Many Asian people saw that and were actually horrified, because for them, the reverence that they had for a lion is not the same as wanting to be eaten by a lion. And they visually connected how this was structured, that they were actually going into the mouth of the lion by entering in through this particular entrance. In fact, they discovered, and as you see here in this picture, there's only 2 people standing outside of it. Very few people went into this particular entrance. They kind of walked around the building looking for another way to get in. It just wasn't appropriate for them. They actually had to reformat, redo the whole entrance, and instead, they used an iconic figure of the lion, resculptured or created a sculpture, goal also, very much recognized as affluence or positive energy, positive luck and everything. And what they found that when the targeted population they were trying to outreach saw this image, many of them approached it, they made gestures, they touched it, they put their hands on it, and then they went into the entrance as they were hoping to do. So again, just because you think something might work for a particular group, unless you fully understand what that group's understanding is, you might have to redo your whole design based on individuals' reactions. So that's just my kind of narrative story that I like to add when I'm discussing cultural competency. And it goes back to, we can learn more from our individuals that we're working with in our communities when we're having that dialogue and exchanging ideas with them. We often say that it's better to talk with somebody than to talk at somebody. And again, I believe that as public health professionals, we're a little bit more keyed into that. But sometimes our role as public health professionals is also to pass that on to others who might not be as aware of how cultural influences can also increase health disparities. That's my presentation. I appreciate your time. I'm going to take any questions or comments that you have. And as I said, it was rather a brief presentation. We do have a fuller, more expansive that includes a little bit more interactive activities and also some different types of forms and other recommendations that are used. But I can be contacted here at Rutgers University and here at the School of Public Health at the Center for Public Health Workforce Development. We're very happy to work with you. I know you're very familiar with us, but we're here, and this is what I do. So thank you very much. Any questions or comments?
All right, if anybody has any questions, you can put it in the chat at this point.
Okay.
All right, Robin says, do you have any advice for making printed or digital forms of health education more culturally competent?
I believe, and I thought my slide actually had the link, but the Center for Cultural Competency at Georgetown University, that's a resource that I often use, and they do have some recommendations. So you can go to their website. I'll make sure that I pass on the correct link that I'm referring to that might have some recommendations. In general, what I'm seeing is when we, instead of using, I mean, yes, our forms sometimes, because we do data collection electronically, we always have the check off boxes, but at the same time, we always need to include the category other, choose not to answer, choose not to disclose, or leave the space for someone to write and what their differences might be, as opposed to just giving them, a limited range of responses.
All right, does anybody else have any questions? Well, okay, Phil, thank you for
All right,
hosting
well,
us
thank you
today.
for inviting me. I hope it was beneficial and looking forward to working our continuing. Okay. Thank you.
Absolutely, it was a pleasure. Everybody will be receiving an evaluation in their email, so if you could fill it out, and in order to get your CHES or MCHES credits especially, just make sure to put your CHES or MCHES number in the field. And that email should go out in a few minutes. So, and everyone sign up for the annual meeting. Everyone have a great day.
All right, thank you, everybody.